Hello, student. First of all, let me know whether I'm audible to you. Hello, student. First of all, let me know. Audio and video, everything is okay at your end. Just give me a thumbs up. Hello, Dr. Deepak. Audible and visible, everything is clear. Thank you. Okay. Right. Perfect. So we are going to discuss the recall MCQs which has been asked in FMG examination 2023. As you know, there are series of lectures and series of discussions going on regarding the recall question. All clear? Okay, thank you. Thank you. So I hope all of you know I'm your new physiology teacher in this platform. I'm Dr. Soumen Manna, right? Okay. Thank you. Thank you so much. Okay. So regarding this session, as you know, this is the recall sessions, all the MCQs that have been asked in last FMG examination that we are going to discuss. But here I'm going to discuss only the physiology MCQs, right? So before going to the actual session, why we are discussing this MCQs? This is only the recall MCQs, and the motive of this live session is to get the actual questions, right? So in your comment section, if you feel that any questions, the options are not correct or proper, or if the questions are not proper, then you can put your comment there. We can revise the question later on. And second thing, we will revise these questions, and this discussion will be helpful for the upcoming examination also. It can be helpful in the even NEET examination also. And all the questions after discussion will be uploaded in the PrepLadder app, right? So this is our basic motto of this session. So without taking much of the time, I'm directly going to start the session. So physiology recall MCQs in last FMG examination. Okay. So you will find out that some of the questions may be overlap between different subjects. Like for example, some of the questions from micro, some of the questions from biochem may be here, but I have sorted them out. I have kept only those MCQs which are completely related to physiology, and the overlapping MCQs which has already been discussed by some of the faculties, I have removed them. Some of them I have removed, right? Okay. So first MCQs is coming in front of you. You must have seen this MCQs, and I think the stem of the questions is looking fine. So what is your answer in this question? I think this question has been discussed in other session also. Anyway, could you tell me what is the answer of this question? And what is the disease? Write down both of the things. What is the disease? They are giving you hint here that a 5-year-old boy, right? So his mother is having significant difficulty in walking, right? Then, yes, at the age of 11 months, he began to walk. 4 months ago, the mother realized that he was having trouble rising from the floor. His calves are bilaterally hypertrophic. So this is another significant hint to these questions. And he carefully rises off the floor, supporting himself with his hand on his thigh. Could anybody tell me what is the name of this sign where the muscles are weak, and to support the muscles, the subject or the patient is rising from the floor by taking help of his hand? There is a name of this sign. Could you tell me, Dr. Prashant or Dr. Suresh, Dr. Deepak? Could you tell me what is the name of this sign? Yes, answer of this question is dystrophin. Okay. But before discussing this dystrophin protein, the name of this sign, very good, Dr. Diba. The name of this sign is the Gower sign. So yes, yes. So this is Duchenne's muscular dystrophy, right? So this is Duchenne's muscular dystrophy. The disease is Duchenne's muscular dystrophy. And the sign here that has been described is Gower sign. So in Harrison's, if you look at the Gower sign, the diagram has been given here. So first here the subject or the patient is lying down on bed, and then he is trying to get up from the bed, okay, and just taking help of his hand, and then giving the supports from his hand, he is actually rising from the floor. So this is the typical typical sign which is known as the Gower sign. All of you know that Gower sign is typically seen in Duchenne's muscular dystrophy. Although it is said that this sign can be seen in any myopathies where the proximal muscles are mainly affected, where the proximal muscles are very weak, then this sign can be seen. So this is a sign general to the muscular dystrophies or myopathies where proximal muscles are weak, right? Okay. But thing is that this is typically positive in case of Duchenne's muscular dystrophy, right? So in Duchenne's muscular dystrophy and the milder form of the disease is known as the Baker muscular dystrophy, right? In both the cases, so whether it's Duchenne's muscular dystrophy or Baker's muscular dystrophy, in both of these conditions, that the protein that is mutated is known as the dystrophin protein, and it has been given that the lifespan of both the patient decreases. Generally, in Harrison, it is given that it is fourth to 5 decade. Okay, and Duchenne's muscular dystrophy is earlier than that. Earlier than that. Okay, death occurs earlier than that. Around 30s के आसपास the death occurs generally, particularly due to involvement of the cardiac problem, right? So this is the two things. Now, question is that the actual pathogenesis that is happening due to dystrophin. Dystrophin protein, it's a muscle membrane protein. Yes, third decades, right? Around 30s के आसपास death हो जाता है. So what we are talking about this dystrophin. Okay, you have to know a little bit more about dystrophin. Just hold on a little. So suppose this is a muscle membrane, right? This is the muscle membrane. I'm drawing a skeletal muscle cell schematic diagram. Okay. Yes, yes. This is very, very important topic. Okay. So suppose this is the skeletal muscle cell. This is a single skeletal muscle cell. In physio, we generally teach you that this muscle membrane, which is known as the sarcolemma. Sarcolemma contain two types of protein. All of you know, this is like any muscle membrane. There will be some protein which will be through and through this muscle membrane, that is known as the integral protein, right? And there will be some protein which will be attached with this integral protein, that is known as the peripheral protein. Suppose this is one protein which is known as the peripheral protein, this blue color protein. Okay, so this peripheral protein which is present in the muscle membrane, that is your dystrophin. That is your dystrophin, right? Apart from dystrophin, the syntrophin protein is also there. Syntrophin protein is also there. So this dystrophin and syntrophin are the peripheral protein. And we say that this pink color protein, which is present through and through the membrane, cell membrane, this is known as the integral protein of the muscle membrane. Integral protein of the muscle membrane. Integral protein, basically two names you have to remember. That is dystroglycan and sarcoglycan. Dystroglycan and sarcoglycan. Both of these protein are the integral protein, right? So this blue color protein that you are finding out here, this is the peripheral protein. This is also peripheral protein. But the pink color protein that you are finding out here, this is the integral protein. Actual diagram, if you look at the book, so see, this is taken from Genong. In Genong, this is given that this dystroglycan. Okay, so this whole complex is the dystroglycan complex. This whole complex is the dystroglycan complex. So as you can find out here, this protein is present through and through the cell membrane. Along with that, this whole complex is the sarcoglycan complex, right? So this is also spanning through and through the cell membrane. So these are known as the integral protein. And this blue color protein that you are finding out here, this is your actually dystrophin protein. This is your actually dystrophin protein. Along with this dystrophin, you can also find out the syntrophin protein. Syntrophin protein, right? So if this dystrophin is mutated, then two diseases just we have seen, that is one is the Duchenne's muscular dystrophy and the Baker's muscular dystrophy. It is said that in case of Duchenne muscular dystrophy, this dystrophin protein is completely mutated, and because of that there will be completely absent of this protein in the cell. Okay, and this Baker muscular dystrophy, there is partially present, the protein is partially absent, partially present, whatever you say. So that's why you have to remember that if the dystrophin is completely absent in the cell, then the severe form of disease, that is the Duchenne's muscular dystrophy. And if it is partially present, then that is known as the Baker's muscular dystrophy. ये दोनों चीज आपको ध्यान रखना होगा. But I'm going back to the MCQs once again. So if you look at the other protein in these options, okay, Okay, if you look at the other options here, all these proteins are they are very, very important for your MCQs. You know, even if this chitin is mutated, there is a myopathies. You know the disease where chitin is mutated and there will be some myopathies. Do you recall what is the name of that myopathies? Okay, could you tell me the answer? So titin is a dilated cardiomyopathy and hypertrophic cardiomyopathy, right? Hypertrophic and dilated cardiomyopathies, right? And this desmins, if it is mutated, then also there will be myopathies, which is known as the desmin related myopathy. Desmin related myopathies. Desmin related myopathies. And this actinin, if this is mutated, actinin or nebulin, there is another protein, nebulin. Any of this protein, whether it is actinin or nebulin, if it is mutated, then there is another myopathies which is known as the nemaline myopathies. Nemaline myopathies, right? This is the different types of myopathies that you have to remember in these questions. Okay. So I hope all of you know that where these titins are present, where these desmins are present, where these actins are present. So if you look at this diagram, I will show you here. Suppose this is one sarcomere, these other two Z line. Inside the muscle cell, there is sarcomere. This is actin, and in between this myosin. You know that from this Z line, the protein which is connected to the muscle membrane, this protein is known as the desmin protein. This protein is known as the desmin protein. Okay, right. Okay, so this protein is known as the desmin protein. And titin is present from this M line of sarcomere up to the Z line of the sarcomere. So M to Z line जो protein होता है, that protein is known as the titin protein. It's an elastic protein. Elasticity of the muscle is modulated by this titin protein. So this is very, very important. I'm telling you that from M line to Z line protein is titin, and desmin is from Z line to the sarcolemma, right? And this actinin protein, where they are present, they are located at the level of this Z line, okay, which attaches this actin with the Z line. So attachment of this actin molecule with the Z line is done by a protein which is known as the alpha actinin protein, right? So these are the important point that you have to remember. So what is important here? We have learned that in muscle membrane, sarcoglycan, dystroglycan are the integral protein, and dystrophin and syntrophin, they are the peripheral protein. So dystrophin mutation we have seen, Duchenne's and Becker's. Now, if there is mutation of this sarcoglycan or dystroglycan complex also, there is also another kind of myopathy which is written here, which is known as the limb girdle muscular dystrophy. So here the particularly the girdle region, okay. So this region of the muscles will be affected mainly in the limb girdle muscular dystrophy diseases, rises. But in case of Duchenne's and Becker's muscular dystrophy, you know that proximal muscles, mainly these calf muscles and these proximal muscles will be affected, and there will be hypertrophy of this calf muscle, pseudo hypertrophy, that is known as a pseudo hypertrophy, because there will be fatty degeneration of the muscles, and that can be seen in biopsies, right? So this is all about the first question. I think most of you know this information because this is a very common questions asked in multiple examination. I hope all of you know this answer. Okay. So now the next question is coming in front of you. This is also an easier question. Particularly my view is that in physiology, most of the question that has been asked are very easier MCQ. So here, the first heart sound coincides with which phase of the cardiac cycle? Yes, answer. Yes, Dr. Megha, Dr. Divya. Okay, I show. So it is not, yeah. So this is, whenever first heart sound is occurring, you have to imagine like this, that whenever, suppose this is heart, okay, and this is your, okay, superior vena cava or inferior vena cava, whatever, and suppose this is your pulmonary artery. Suppose this is your pulmonary artery. So whenever heart will start contraction, right? The main thing is that heart is going to eject blood at the level of this pulmonary artery. If I am thinking of the right ventricle, suppose, right? So if I have to eject my blood at the level of pulmonary artery, what you have to do? First of all, you have to close the valve which is present here. Okay, that is the tricuspid valve. So whenever the heart will start contraction, the first thing that is going to happen is closure of the tricuspid valve on the right side and the closure of the mitral valve on the left side. So basically, closure of the tricuspid and mitral valve will occur at the onset of systole, at the onset of systole, at the beginning of systole. And the first phase of systole is known as the isovolumic contraction phase. Why? Because you know, whenever this tricuspid valve is closed, pulmonary valve was already closed from the previous cardiac cycle. So this valve is closed, this valve is closed. Okay, heart is contracting with the same volume of blood. That's why the phase is known as the isovolumic contraction. So at the beginning of the isovolumic contraction, even if I give you option like this, that isovolumic contraction beginning or ending of isovolumic contraction, again your answer will be beginning of the isovolumic contraction or beginning of the systole. Okay. So please remember that these two heart sound, these are also important for your MCQ. So the first heart sound and the second heart sound. We say that first heart sound occur at the start of isovolumic contraction, and second heart sound occur at the start of isovolumic relaxation. Okay, at the start of isovolumic relaxation, very very important. So whenever the heart is starting is systole, first heart sound will occur, and whenever the heart is starting is diastole, the second heart sound will occur, right? Along with that, you have to remember that the second heart sound, it is S, that is the soft. Okay, it is short and it is sharp, right? These three things also have to remember. Second heart sound property. Soft means it is a low amplitude sound, means if you measure the decibels of the sound, then it's a low amplitude sound. Amplitude of the sound is a low. Okay. Short in duration. So the duration of this second heart sound is only 0.12 seconds. So it is a shorter sound. And sharp means this is a high pitch sound. This is a high pitched sound, right? High pitched sound means around 50 hertz is the frequency. Okay, 50 hertz is the frequency of this second hertz sound. On the other hand, if you look at the first hertz sound, so it is loud. Okay, so amplitude is a very very high, so it's a loud hertz sound. Then it will be longer in duration. It will be longer in duration. 0.15 second is the duration. This has also been asked in various MCQs, and this is a low pitched sound. First hertz sound is a low pitched sound with a frequency of 25 to 45 hertz. Okay, so this many information you have to remember for two types of heart sound. But along with that, you know, sometimes this question is also given that if you record the ECG along with the heart sound, then how to understand that which heart sound will correspond with which wave of the ECG, right? So I told that first heart sound occur at the beginning of systole of the ventricle, right? Beginning of the systole of ventricle. So whenever the ventricular systole is occurring, you require ventricular depolarization. Otherwise, the ventricle is not going to contract. So ventricular depolarization means in the ECG, we know that QRS complex is the ventricular depolarization. That's why the heart sound that is marked here with the B, this heart sound is corresponding with the peak of the R wave. So peak of R wave correspond with the first heart sound. Please note down because it is corresponding with the systole of the ventricle. Now, whenever there is diastole, I told you that at the beginning of the diastole, the second heart sound occur. Diastole means before the diastole starting, there should be a repolarization of the ventricular muscle. And ventricular repolarization is denoted by which wave? T wave. So the heart sound which is appearing just at the later half of the T wave or at the end of the T wave, this heart sound is the second heart sound. So at end of T wave, okay, the heart sound which is appearing, that is the second heart sound, right? समझ में आ रहा है? So first heart sound and second heart sound, you have to remember like this, that ECG wave, first heart sound is with peak of the R wave, second heart sound at the end of the T wave. Now, third and fourth heart sound, could you recall what is the cause of the fourth heart sound? Fourth heart sound occur whenever there is contraction of the atrium. Because you know, atrium contraction will leads to rapid filling of the ventricle, and that rapid filling will produce vibration in the ventricular wall, and that will produce fourth heart sound. So fourth heart sound means This corresponds with the atrium contraction. Atrium contraction, right? So atrium contraction means you require atrium diastole, and then only the atrium contraction will start. So atrium systole. So atrium systole means there will be depolarization of the atrium. Depolarization of the atrium is denoted by which wave in the ECG? P wave. That's why this is the P wave. The heart sound which is corresponding with this is nothing but the fourth heart sound, right? So this is my fourth heart sound. So this is my first heart sound. This is my second heart sound. This is my fourth heart sound. And in between, the heart sound which is falling on the TP segment, T and PK beach major segment, this TP segment, the heart sound which is falling there, that will be your third heart sound. That will be your third heart sound, right? So this is TP segment. This TP segment is known as the isoelectric segment of the ECG. So the heart sound which is corresponding with the isoelectric segment, that is the TP segment, and fourth heart sound will fall at the end of P wave, at end of P wave in the ECG. So this is very important. Okay, very important. Yeah, that is coming. That is the second question. This is not the JBP question. This is the question of heart sound along with the ECG. Okay, so this is heart sound along with ECG. Now this question you are asking, I think, Dr. Rafiq, the large VOA was seen in which of the following condition? Okay, so this is the question which is related to your JBP, jugular venous pulse, right? So answer batao ये question का. So by the time I'll draw a JBP, so this is the typical diagram of the JBP, right? Yeah, look at here. S1 sound. So this x-axis, आप समझ में आ जाएगा यहाँ पे देखो. So this x-axis is the time axis and y-axis is the right atrium pressure. So if you record the right atrium pressure, that is your JVP, है ना, jugular venous pulse. So basically jugular venous pulse give you idea of the right atrium pressure. Okay. So now you think of that this is your heart. Okay, this is your right atrium of the heart and this is the right ventricle of the heart. Only right side of the heart I am drawing. Okay. So whenever this right atrium will contract, what will happen? The pressure inside this right atrium will be very high, right? And this increase in pressure, you are recording in a graphical representation. So this wave, okay, which is rising upward, this is due to atrium contraction. This is known as the A wave in the JVP. So I can write down the A wave means this is due to atrium contraction. This is due to atrium contraction, right? Now, after the atrium contraction is over, how will happen? Okay, that question I didn't get. Maybe the medicine teacher will discuss this decrease in heart sound and no murmur. Okay, but I didn't get that question in my session. Okay, sorry for that. Okay, now see. So A is the atrium contraction. Now after atrium contraction, atrium will start relaxation. So whenever there is relaxation of the atrium, there will be descent. Okay, so this is known as the X descent. Okay, but in between X descent, what will happen? This ventricle will start contraction. Now, whenever ventricle start contraction, okay, just now we have discussed at the beginning of the ventricular contraction, what phase that is? That is the isovolumic contraction. So when the atrium is contracting, look at here, when the atrium was contracting, okay, could you tell me this A wave is happening when the atrium is contracting? This will correspond with which phase of cardiac cycle? Which phase of cardiac cycle? This is phase of diastole or systole? This is phase of diastole. This is known as the last rapid filling phase of diastole. Last rapid filling phase of diastole. So when the atrium was contracting, when the A wave was appearing in the JVP, that time ventricular filling was going on. Now the ventricular filling is over. Now the ventricle contain a blood volume which is known as the end diastolic volume. With this end diastolic volume, whenever the ventricle will start contraction, the first phase of contraction is isovolumic contraction. At the beginning of the isovolumic contraction, there will be closure of this tricuspid valve, and I told you that will correspond with the first heart sound. So the first heart sound will almost correspond here. The first heart sound will almost appear here, just at the beginning of the C wave. just at the beginning of the C wave, that time the first person will appear. Okay, now look at. So now the tricuspid valve is closed, ventricle is contracting. Okay, okay. So ventricle is contracting. Whenever ventricle is contracting, there will be bulging of these valves towards the atrium cavity. And whenever there is bulging of the valves, there will be increase in pressure. Okay, in the atrium, that increase in pressure will be denoted by the C wave, right? There will be further relaxation of the atrium, and that is known as the X descent. Okay. Now the question that has been asked here, that is regarding this V wave. Okay. So this V wave means I can find out that there is gradual rise of pressure in the right atrium, and that is due to inflow of the blood from superior vena cava and inferior vena cava. Getting my point? So easily we say that C wave and V wave. C wave is C for cusp and V wave is for venous return. So venous return means whenever the atrium is relaxing, the superior vena cava and inferior vena cava is draining their blood inside this atrium, and atrium volume is gradually rising. Okay. So gradually rising means what will happen? The pressure will rise gradually, and that is the V wave, right? So this why V wave means venous return wave. Now look at, in this case of tricuspid regurgitation, normally the venous return is coming from the superior vena cava plus inferior vena cava. This is equal to venous return. Whenever there is regurgitation back of blood from right ventricle to the right atrium, इसके साथ the tricuspid regurgitation blood will also add up. What will happen? The venous return will be more than that of the normal, and because of which this large V wave will be seen. So that's why. So this large V wave is seen in the tricuspid regurgitation. I hope all of you know this answer. And some of the other question that you have to remember, that prominent A wave is seen in which condition? Okay. Canon A wave is seen in which condition? Absent wave is seen in atrial fibrillation. Large V wave just now we have discussed, that is a tricuspid regurgitation. Along with that, you also have to read this thing, that sharp Y descent and sharp X descent. Okay. Aortic stenosis will be option over, so it will not change. Okay. Only the tricuspid regurgitation is the possible answer. Okay. So these are the things that you have to remember about abnormality of the JV. Okay. Now we should go to the next question. So this next question is a very, very simplest form of question. Okay. All of you know that here the question is about the extrinsic clotting factor. Okay. In our body, whenever clotting starts, it starts from the extrinsic pathway. Extrinsic pathway, right? Intrinsic pathways start from the factor number 12, which is activated by various other factors, and extrinsic pathway means the tissue factor and factor 7. So this factor 7 is the answer here. Tissue factor and factor 7 is responsible for activation of the extrinsic pathway. So see here, all of you know that this is the extrinsic pathway of clotting factor, and this is the intrinsic pathway of clotting factor. I am not discussing the detail. So here you can find out that the tissue factor and this factor 7, they are starting this. Okay. Factor 9 was also there, no problem, but factor 9 is part of this extrinsic pathway only. Factor 10 onward, we say that is a common pathway, common to extrinsic and intrinsic. But whenever we say extrinsic pathway, this is exclusive of this tissue factor and the factor 7. That is the starting point of the extrinsic pathway. Now this tissue factor, all of you know that all of this clotting factor has been given here. Tissue factor is generally known as the factor 3. So this is the tissue factor. And this is the factor 7, right? So this is the factor 7. And I will tell you here that this half-life of the clotting factor, this is one important thing. Okay. Please remember the shortest half-life clotting factor. All of you know here that this factor 7 has the shortest half-life. Only 5 hours is the half-life of this clotting factor. And the maximum half-life is this 13. Factor number 13 has the maximum half-life, that is around 200 hours. This you remember so that your future MCQs can be solved. Okay. So this is all about this question. Next question I'm coming here. Now this question, I could not get the detail of the question, but there was probably a question on myosin. But myosin is derived from which amino acid? Some of the students are saying, but that's a very absurd question because it's a very long protein where multiple amino acids are there. So I am requesting you, all of the students, if you could recall that there was a question regarding myosins. So if you could recall the options of these questions, please do post in the chat box of this MCQ. Otherwise, the possible question that may arises from myosin and actin. Okay, please remember, no question like that. Okay, it was tyrosine amino acid. Okay. So that's why the thing is that. But probably if the question is on myosin, see here the molecular weight is very, very high. So they cannot ask you that myosin is composed of which amino acid. That's a very absurd question. Possible nahi hai. But what you have to remember, this can be a future MCQ. That myosin is composed of total 6 chains. 2 heavy chains are there and 4 light chains are there. Okay. And this 2 heavy chain is forming the tail of the myosin, and head of the myosin contain this light chain. So please at least remember that there are 4 light chain and 2 heavy chain. But if there is no such question, no problem. But this is only for the future MCQs. And regarding actin, you remember actin is basically known as the ape actin. So if I say that this is an actin, this is a filamentous actin. Filamentous actin is known as the ape actin. Okay. And this ape actin is composed of multiple subunits which are spherical in nature. They are known as the GI. So normally the actin which we talk about, the muscle contraction or the cytoskeleton element, the actin, this is known as the F actin. And F actin is composed of multiple small subunits which are known as the G actin. Okay, this much information you remember. But if you could recall the MCQ regarding myosin, please do post here. Otherwise, no problem. Okay. Now next question here, melanin and tyrosine. Okay, so that's a different question. Okay, so which of the following is true regarding creatinine clearance? So again, it's a very easy question. Clearance is equal to inulin clearance. So if clearance of inulin, we all know that inulin means there is no secretion, no reabsorption. Clearance of inulin is equal to GFR. Okay. Whenever there is secretion of any substances, then clearance of that substances will be more than inulin clearance or more than GFR. এই তো না? So basically we know that clearance formula is UV upon P. UV is what? Urinary concentration and urinary flow. So if you multiply this, this is basically urine amount of any substances. Urinary amount of any substances, urinary amount of any substances upon your plasma concentration. So if you measure the urine amount of any substances upon the plasma concentration, then you will get the clearance. Now, urinary amount means it can reach from the process of filtration. I am asking that urinary amount means urine में जो substance है, where from it is coming? It can reach from the filtration or it can reach from the secretion. But if there is reabsorption, then you have to subtract that from this total amount upon your plasma concentration. So this is my final equation. Now, if I modify this equation for clearance of inulin, we know inulin means there is no secretion, no reabsorption. So clearance is only the filtration upon your plasma concentration. That means it is nothing but filtration rate. Filtration rate. So filtration rate per 1 minute is GFR. That's why we say that clearance of inulin is equal to GFR. Why? Because clearance of inulin means it is nothing but filtration amount upon concentration. Filtration amount upon concentration means filtration rate, and that is GFR. Now suppose clearance of creatinine. So creatinine means there will be secretion of these substances in the nephron. So whenever there is secretion, the formula will be like this: filtration plus secretion upon your plasma concentration. So obviously, if we compare these two, एक में numerator is only filtration amount, and in second filtration plus secretion. So obviously, we can understand that this creatinine clearance will be more than that of the inulin clearance. Same way, whenever there is absorption of any substances in the nephron, then the clearance of that substances which is getting absorption in the nephron, it will be lesser than that of the clearance of inulin, right? So that's why this is very simply and direct answer that creatinine clearance is a little greater than inulin clearance, only 10% greater. There is another such substances which is secreted in the nephron. Okay, secretion in the nephron, that is the PAH. You also have to remember this, para amino hippuric acid. Okay, para amino hippuric acid का secretion होता है 80% of the total filtration volume, and creatinine का जो secretion होता है that is only 10%. So in both the cases, para-amino hippuric acid clearance and the creatinine clearance both will be greater than that of the inulin clearance. But para-amino hippuric acid clearance will be much greater than inulin clearance, and creatinine clearance will be slightly greater than inulin clearance. Means more the secretion, more will be the greater volume, greater inulin clearance. Okay. So this is the two things that you have to remember. about the inulin clearance and creatinine clearance. Okay, समझ में आ गया? ठीक पेन? Okay, पेन छोटा हो गया? This PA, yes, this is used to measure the renal plasma flow. Very good. This is used to measure the renal plasma flow, and this inulin is used for measuring the GFR. But rather than inulin, clinically we use the creatinine clearance. Okay. Next question. This question has slightly greater roles in the option. Very good. Very good. Okay. So that will be slightly greater, because if it is pH, that will be hugely greater. Okay. Very good. So now this question, again, the ENT faculty must discuss this. I know that utricle and saccules. Okay. So these are responsible for, what is your answer? Okay. Bold pen. Okay. Bold pen कर लेता हूँ. What will be your answer? बोलो. Yes, linear acceleration, right? So this angular acceleration, this is the feature of the semicircular canal. This is the feature of the semicircular canal here, this angular semicircular canal. But in this question, the question answer will be linear acceleration. So here the answer is linear acceleration. Okay. So I'm not taking much of the time, but this diagram, I hope all of you know that this internal ear, this cochlear, this is responsible for, okay, hearing functions, because your organ of corti is located here, right? Then this utricle and saccules, either. This is the question that has been asked here. Okay, this is responsible for acceleration or deceleration. Okay, maybe vertical or maybe horizontal plane. Both the cases, this utricle and saccules, and this semicircular canal. Okay, so this AC, HC, and PC, these are the semicircular canal. Okay, anterior, posterior, and horizontal semicircular canal. So there is an area here which is ampulla. Inside this ampulla, there is a sensory organ which is responsible for angular motions, right? So all this thing has been written here. So if it is cochlea, then the organ of corti is the sensory receptor there, and it is responsible for hearing. All of you know. Semicircular canal, the pista is the sensory organ here, and it is responsible for angular acceleration. And if it is the otolith organ, which contain a sensory receptor which is known as the macula. Okay, inside this this macula is present inside this utricle and saccules, and utricle is responsible for horizontal acceleration and saccule is responsible for vertical acceleration. So basically all of them, whether it is horizontal or vertical, this is nothing but your linear acceleration only. Angular acceleration is a function of the semicircular canal. Okay, and this hearing in low frequency or high frequency, this is basically function of organ of cortex, right? So this is balance. Yes, this is maintenance of your balance whenever your head is tilting or whenever your head is accelerating or decelerating. That is basically maintenance of your balance, because whenever this organ is activated, this will send signal to the vestibular nucleus, and from there the spinal muscles will be contracted to maintain your balance. That's why we say that this is responsible for your balance, right? But specifically, you have to remember which one is the angular and which one is the linear. Okay, that's the question. And now the next question. So the next question is the causes of death in diabetic ketoacidosis. This answer of this question is, what do you think? What is the answer of this question? Yeah. So diabetic ketoacidosis, person is suffering from diabetic ketoacidosis, one of the very dangerous complication where blood glucose is very high. Because of the high blood glucose, what is happening? The osmolality of the blood is very high, right? Yes, very correct answer. That D is the answer here, cerebral edema. Okay, and it is said that this is the most common causes of death in case of diabetic ketoacidosis complication, particularly in case of children. And the causes of death, that why there will be cerebral edema in case of diabetic ketoacidosis, why there will be cerebral edema, the causes is still debatable, but the scientists are predicting that because of this high blood glucose in the blood, the osmolality of the blood is very high. Now whenever you start giving fluid therapy to this patient, if you correct the fluid therapy, if you give the fluid therapy in a rapid manner, rapid correction of the fluid, then what will happen? This blood glucose will be diluted and the osmolality of this blood will fall. Whenever the blood become hypoosmolar, okay, what will happen? The water will enter inside this brain cell and that will leads to edema inside the cell. So this is the probable reason of cerebral edema. But many scientists are saying, and recent report are saying that not only this correction, rapid correction of water, that is not the reason. Even before that, there is already damage of brain cell even before the starting of fluid therapy, even before the starting of treatment in case of diabetic ketoacidosis patient, and that is the causes of cerebral edema. Okay, so again, I am saying that exact cause is not known that why there will be cerebral edema. It is debatable, but one of the most common cause it is said that correction of the fluid, if you do rapidly, then the osmolality of the blood will change and that will lead to cerebral edema. But some reports are also saying that pre-existing brain injury will already be there before the starting of fluid therapy. So this is the cause of cerebral edema, and cerebral edema is the most common cause of death in diabetic ketoacidosis patient. I think this much MCQ are there in physiology session. So this is all about physiology MCQs. Now all of you know that PrepLadder has started one elite plan for next entrance examination. Okay. If you want to join this plan, please pre-book. Pre-booking has started already from 21st January. Okay. One question was there in hemoglobin type AB3. Okay, ferritin iron. I didn't get that question. Maybe your medicine teacher or maybe biochemistry teacher will. I didn't get that question here. Okay, no problem. One question was the hemoglobin ABF. I'll include. I'll try to include that question. Okay, I'll try to include and it will be uploaded in the PrepLadder app. Okay. So in this elite plan, all of you know that there will be updated and new videos of 19 subjects, and I'm taking the physiology there. You will get the English version as well as Hindi English version of the lecture. Plus, you will get the next edition question bank, and that question bank contains 70% of the clinical question. Notes will also be given, treasures, rapid revision, and snapshot video will also be there. Mock test will also be conducted, and past year MCQs, previous year MCQ discussion will also be there in the session, right? Total kitna questions? Around 9 to 10 questions were there from physiology. Around 8 to 9, 9 to 10 questions were there in physiology, right? So this is all about physiology discussions. Thank you so much for joining, all of you. Take care. Bye bye. And I'll update regarding your feedback. Thank you so much. Thank you, Dr. Pickle. Thank you so much. Bye bye. Take care.